Assalamu alaikum. Uh, I think this is maybe the only presentation about vulvar cancer in this prestigious conference. And I think that vulvar cancer is always neglected in our meetings and even in our practice. This may be the main stimulus to me to talk or speak about this issue. Is it a rare disease? I don't think so. When we started in our gynecologic oncology unit, we faced a considerable number of patients. As we all know the situation in Egypt, there is always no statistics, so we have to look for the international side. The American Cancer Society says that around 1 in 333 women will have a chance of developing vulval cancer all over her life. It is expected to face around 6,470 cancers newly diagnosed this year, with around 1,670 women will die. This means that this is an aggressive cancer. I can't talk about statistics in Egypt, but I can say that vulval cancer stands side by side with cervical cancer. It is not uncommon. Second, vulval cancer is an aggressive disease when it goes to the lymph nodes. If we can diagnose vulval cancer at an early stage, it might be a curable disease. This is from the third database, where, as we can see, for an early stage local disease, the survival rate is approaching 90%, while when it goes to the nodes, when it becomes a regional disease, the survival drops to a half, almost 40%, and even much lower when it comes distant. So it is very important not only to know about this disease, but also to detect early and to treat early. Second, there is a malpractice in our treating of such cases. As a gynecologist, I assume that every case that faced us as pruritus vulvi took an empirical treatment 1 or 2 times before she can be assessed carefully and to check whether she has a susceptible lesion or not. The spectrum of vulval disorders is wide and it varies from infections, dermatosis, manifestations of hormonal or even systematic disease as psoriasis, up to cancer or precancerous lesion. And it is always, when we find such lesions, it is difficult to distinguish between the precancerous and cancerous lesion and the other lesions. And usually a biopsy is needed. And in our practice, I think to have a decision of having a biopsy is usually delayed, and mean that if we delay in taking the decision of biopsy, we delay in the diagnosis, and most of our cases will come to us late. The terminology is very important. In 2015, the International Society for the Study of Vulvar Diseases set the terminologies for the lesions into low-grade squamous intraepithelial lesions, and this included the past terminologies as VIN1, flat condylomas, or HPV infected lesions. The second is the high-grade squamous intraepithelial lesions, which included VIN2 and 3. The third is the differentiated type vulval intraepithelial neoplasia. In 2020, the WHO subclassified into HPV-associated squamous intraepithelial lesion, which includes the high-grade type, and this is usually have HPV positive or HPV related, and the HPV independent VIN, which includes the differentiated vulvar neoplasia, and then they subclassified into 3 types: differentiated VIN, exophytic differentiated VIN, and vulval acanthosis. I will not go through the details, but we have to know some of the anatomy and the histology which can aid us in the diagnosis. The vulva is not only the external genitalia of the female, but it also includes the external urethral meatus, the perineum, the perianal area, and these structures differ embryologically and histologically. The vulval epithelium and the appendages are ectodermal in origin. The dermis is mesodermal in origin. And the only structure that is derived from the endoderm is the bladder, the urethra, and its vestibule. And so, the appearance of the lesion largely depends on the tissue from which it originates. For example, for the vulval skin, the mons pubis, the lateral aspects of the external genitalia of the labia majora and the perianal regions contains keratinized squamous epithelia, which is hair-bearing, while the inner parts of the labia majora and the labia minora and the clitoris is covered by non-hair-bearing skin. The vestibule is covered by non-keratinized squamous epithelium. Also, according to the age group, according to the response to the sex steroids, the skin differs, and all this will affect the shape of the lesion or the lesion that I will detect, and also will differ in my evaluation when I check for these lesions. In addition, the anogenital epithelium is all of it that is derived from the cloaca, including the cervix, the vagina, the vulva, the anus, and the lower 2 centimeters of the rectal mucosa. As they share the same embryologic origin, and as HPV is usually responsible for such lesions, so vulval cancer may be multifocal, occurs in multiple sites in the same area, or multicentric and occurs in multiple sites. And this raises the issue as we are going and expanding our programs for early detections of cervical carcinoma. Why not to extend to check for vulvar lesions, as they are easier? The initial step for any examination is just inspection, and if you check for any lesion, go through for further detailed examination. And as we will talk, the detailed examination, we can use the colposcope, which also being used to check for the cervical cancer. So why not to extend our practice to check for vulvar lesions? The risk factors are very important for prevention. We all know that vulval cancer is usually associated with HPV infection. And the stigma of HPV infection as a sexually transmitted usually makes fear to speak about with our patients about such case. And here I quote this from slides from my friend Dr. Basil, that there is also non-sexual transmission of HPV, and this we can use to debate or to discuss with them that it can be. And this is my personal assumption. If we are speaking about external genitalia lesion, this may have a higher percentage of non-sexual infection than the cervix, which is inside the vagina. This study showed the HPV testing in the vulva, and as we can see, the low-grade serous intraepithelial lesions has the lower risk HPV types 6 and 11, while the high grade having the higher risk groups 16, 18, and 31. And so the high grade is have higher percentage to progress to invasive carcinoma. And here, if it is related to HPV, well, the vaccine that we are giving will protect against the development of vulvar carcinoma or not. The answer till now is it may protect against vulvar carcinoma. So we can speak about vulvar carcinoma also as a preventable disease, and we can eliminate also as we speak about cervical carcinoma. And in this study, it showed that there is a reduction Actually, this study was speaking about the use of vaccination in elimination of cervical cancer, and as an ancillary, they put their the lesions about the vulval and the vaginal and so on. And if you look at the last column, we will find that there are many lesions that have been protected, that the risk reduction is approaching 90 and even in some lesions for 100%. Other risk factors includes immunodeficiency, include cigarette smoking. I think this for our locality is not so common. I added some slides, maybe it was not addressed more in the literature, which is the effect of diabetes. In my personal experience in our unit, almost more than 90% of the patients that are having vulvar cancers are diabetic. I think this is there is a strong association between them. I searched for the literature about the association between diabetes and vulvar cancer, and I found nothing. But I found many literature addressing the relation between diabetes and gynecologic cancers. This is what I found, that diabetes may overshadow and can delay the diagnosis of vulvar cancer, as it causes chronic irritation and inflammation and may cause rapid progression of the disease. Epidemiological studies that have said that the incidence of vulval cancer with other cancers are higher in the diabetic population. Presumed mechanisms about the diabetes and also diabetes treatment for having the progression into cancer or developing cancers. All are these assumptions, but there is no specific study that addressed the issue between diabetes and vulvar cancer, even on the epidemiology for vulvar cancer. Vulvar dermatosis, and this is very important for the non-HPV dependent lesions, where we will speak about the lichen sclerosis, the melanoma in situ, the Paget's disease. The second step after the HPV vaccination is for the diagnosis and detection of the intraepithelial lesions and early cases. Till now, screening is not recommended. Universal screening for vulval cancer is not recommended. But the early diagnosis is mandatory for every gynecologist. The diagnosis includes first alarming sign is the symptoms. And symptoms, the main symptom is pruritus. Although many lesions are asymptomatic, but pruritus is a very alarming sign, especially when it is not responding to treatment. And I think in all our practices we face many patients who are, especially the diabetic patients also. Other symptoms include vulvar pain, burning, dysuria, where dysuria mainly may be in the periurethral lesions. Second, in contrast to cervix, cytology is not recommended for vulval regions. This is because it has a thick keratin layers that covering the epithelium, and so there will be suboptimal cellularity, and so the smears will not be effective in detecting the lesions. And as we will find scarce cellularity, and many studies have addressed this issue. So the most important is the examination and the careful examination and to take a biopsy. And here is the concept of the valvoscopy. Valvoscopy is a more reliable, and it is different from colposcopy. It starts from the examination first, and then after examination we can do acetic acid, and I will speak about it, and then the Collins test is abandoned now, and biopsy. The visual examination starts even without magnification for the entire vulval region, and we should examine in a systematic way for all the hair-bearing and the non-hair-bearing areas, including the vestibule and periurethral area, the perineum, and the perianal area. Sometimes if the lesions are extending to the anal canal, specific examination and procedures may be requested or required to examine into the interior of the anal canal. If magnification is required, we can use a magnification lens, and also we can use the colposcope. Application of acetic acid may be beneficial, but as the epithelium is keratinized, we need a higher concentration and to apply acetic acid for a longer duration. That's why it may not be so beneficial and may be messy during the examination, but it may be helpful not in detecting lesion, but to detect the extension of the lesion, so that I can take an accurate biopsy or even for excision later. As we can see in such case, the lesion for high-grade intraepithelial lesion, it is in the perineum and extending into the anal verge, and this may be missed in the biopsy. Acetic acid has a high sensitivity, about 97%, but it has low specificity. So the extension, it is very helpful to reassure the clinician that high-grade vulvar lesions are not present. But if there is acetoid areas, we have to take a biopsy. And as I said before, it is helpful to detect the position and the extension of the lesion. Colon tests using toluidine blue has been abandoned. The biopsy, we have to take into consideration that there is in around 60% of the cases there is a multifocal lesions, there is a multicentric lesions and synchronous lesions. So we have to take multiple biopsies from all the suspected area and even from the areas which are not suspected. When to take a biopsy? A biopsy is mandatory in fast-growing lesions, in ulcers that is present more than 1 month with fields of bleeding, or from suspicious lesions with discolorations, areas of indurations, lesions that are resistant to medical treatment, or there is failures of previous therapies. So when we take a biopsy, there is abnormalities. The classification of abnormal vulvar findings has been proposed by the International Society for the Study of Vulvovaginal Diseases and the International Federation for Colposcopy and Cervical Biopsy in 2012. And they classified and defined the normal findings and the abnormal findings, and each biopsy and each examination and vaginoscopic evaluation should include such terms in order to unify our language and to understand what we are speaking about these things. And actually every lesion, macule, patch, papule have a definition, where macule, for example, is a small lesion less than 1.5 centimeter with area of color change and no elevation and no substance. So if I say I have 1 macule or 2 macules, you can know what I mean. The second, we have not to ignore the non-HPV lesions, and here I will speak about the extramammary Paget's disease. And the problem in Paget's disease that it mimics many vulval pathologies, and it is usually mistaken for chronic dermatitis or dermatosis. And even the histological diagnosis of the disease is not so easy and need pathologist who is specialized in dermatopathology. When we check for by inspection, it will look a red excoriated area with shades of white and gray eczematous and ulcerated area, and most of them are on the labia major as seen in this lesion. The second non-HPV site is the melanoma in situ, and here the biopsy should include the dermis to include to allow the diagnosis of the melanoma in situ. Actually, it is an uncommon finding to have pigmented vulval lesions, and it may be indistinguishable from other lesions. But asymmetry or indistinct borders, the color which is, let's say, variegated or dark, having a large diameter or increasing size may be suspicious alarming signs to check for these pigmented lesions as خلاص. طيب انا هتكلم بسرعه. for the treatment we include for the low grade serous, low grade squamous, we usually follow up because it is very rare to be progressed. For the high serous, we have to either excise or other lesions that can be used medical treatments or topical treatments or ablative treatment. And this protocol, this algorithm is in up to date, and we adopted in our local unit how to check for the lesions and whether there are risk factors to go for excision or either no risk factors to check for ablation. For the surveillance, even after treatment of the patients, we have to do surveillance for the patient follow-up every 6 months for at least 5 years, and then monthly or annual follow-up, because the incidence of recurrence may approach up to 8%. The risk factors for recurrent disease is immunosuppression, multifocal, multicentric, large-sized lesion, age, the age more than 50, positive margins after excision, risk factors, and don't forget diabetes. And thank you very much.
Thank you very much, Hisham, for